aspect of ophthalmology, not as cataract surgeons, as retina specialists. Whenever we have problems of cataract with other issues, they have to be co-managed as a team, and that's why we have to be very, very focused on patient-centric care. So this is one of those sessions, and I have the pleasure of inviting the chairpersons, Dr. Lalit Verma, Dr. Kim Ramaswamy, Dr. Murlidhar, Dr. Vinita Gupta. Unfortunately, there are less chairs here, less than the number of chairpersons here. So, and Dr. Vishali Gupta and Supriya Daber and Dr. Shankar C. I am Dr. Raja Narayanan from LV Prasad Institute. Without much ado, we'll start off with the first talk. It's on retinal vein occlusion by Dr. Sangamitra. See here. So the assumption is if someone is not here, they are in some other session. So if he is not there, we can go to the next talk, diabetic macular edema, Dr. Raja Narayanan. Is he here? My talk is on cataract with lamellar macular hole, not a very common kind of, I would say, among all the retina problems. Macular hole, which is much more common, or the other conditions which other speakers are going to talk about. But the point is that whenever we have a patient, we look at the patient as a whole. That will be the topmost message it will come out. But otherwise, after that, what happens is mainly for retina surgeons. I think cataract surgeons don't have much to do with the lamellar hole other than refer or work as a team. So, a lamellar macular hole is not a full thickness macular hole which we all know about, but it's the inner layers of the retina which are thinned out. There's still some external retina which is still remaining, and it can be associated with ERM or lamellar hole epithelial proliferation or LHEP, and it may have an undermining of the edges usually, or it may have other problems associated with it like disruption of the ellipsoid zone and the ELF. There are two types, one is the tractional type and the other is the degenerative type. The degenerative type is more common in normal circumstances when you see. The tractional type can be seen in high myopes as well. It can be seen in the MTM classification also. But when someone is faced with a cataract and a lamellar macular hole, the point here is you must consult a retina specialist who will work as a team with the cataract surgeon. Don't just, the best way is to be with the patient together, at least call up the patient. One of the less acceptable form is just send the patient and not know what is being done to the patient by the retina surgeon. But at least it's still better than not sending to a retina specialist also. But what will happen is the retina surgeon will also evaluate the retina along with the cataract, and we can come to a conclusion or communication with the patient as to how much is the improvement going to be after cataract surgery. This is the biggest dilemma that cataract surgeons may face, because we all know in retina speciality we don't give 20/20. Retina surgeons are not 20/27, but we at least maintain the vision in progressive chronic disease. We don't let them go blind. But instead of telling a patient you have cataract, operate, and then patient is unhappy, then we have to not just manage the patient's expectation but the cataract surgeon's expectations also. Instead of that, let's work as a team. So what could be the different scenarios which may come up? Some lamellar holes actually may not need a surgery. They are usually associated if the outer segment photoreceptors are good. They do get good surgery. So that becomes like a pure cataract surgery. Cataract is significant, go ahead and do the surgery. But if there is an issue, whether a retina surgeon decides that you have to do retina surgery vitrectomy, then the dilemma comes, what kind of practice do you have? Is it sequential? Should I do cataract surgery first, then go for vitrectomy, or the other way around, or is it a combined? But either way, the communication has to be done and avoid the VIP syndrome. Whatever happens, generally, if a patient comes, typically we tend to do our stuff first and then to not communicate anything to the patient or the other specialty doctor also. I will do my job and then we will see and send that patient if there is an issue later on. Let's work as a team. So in this case, there are two cases that I am going to present. One is a degenerative form, one is a tractional form of lamellar roll, which I had mentioned. A patient from Nagpur was actually referred here to us, and he had 20/100 vision in the right eye. As you can see, in the OCT, you can see the degenerative type of lamellar roll with the photoreceptor or the outer retina more or less intact. And based on this, we can actually communicate with the patient that your visual recovery is going to be likely to be substantial. There are cases where 20/100 may remain only 20/100 also after surgery. That you will tell that this is to prevent further vision loss. But in this case, it is likely that this patient is going to improve further. So in this patient, we took up the patient for surgery with ILM peeling, which is foveal sparing. And I'll come to some article on publication on that patients in lamellar hole, you should peel the ILM, but you should not do a complete peel. You should spare the fovea because they can have other complications. So the routine PVD induction and careful, it's a hyaloid vitreoskisis which is usually there. That's why these patients have the degenerative. You see a careful transition of staining, then brilliant blue staining, and when I'm peeling the ILM, it will be spared over the center of the fovea, and with a scraper or a finesse loop, you can gently push it over. And this is what the post-operative OCT is. In this patient's vision is 20/25. You can see that the undermined edges of the lamellar hole which was there, it has become more or less a normal contour now. In another patient where we did cataract surgery along with lamellar hole surgery with ILM peeling and foveal sparing, and along with that I had to inject Ozurdex because this patient had significant edema during the, before the surgery was done. So this patient improved significantly. As you can see, there was edema, it was settling down later on, and at 1 month the vision was 20/30. And this was one of the articles which I was alluding to earlier, that in patients with lamellar macular hole, if you do a conventional ILM peeling versus an LHEP embedding, that is, you invert it and embed it within the so-called hole, partial hole, those patients have better visual outcome and the macular hole formation is significantly lower. In LHEP embedding it was 0, whereas in the other patient it was more than 10% cases at full thickness macular hole development later on post-operative. So I'm just going to conclude here that lamellar holes are slowly progressive if at all. Here the symptoms are also given due importance to metamorphosia. Cataract surgery can be performed as stage or simultaneously depending on the grade of cataract and the surgeon's preference. And teamwork is extremely important. Thank you all very much for your time.
Thank you, Raja. That's a very important topic, but to decide on referring these patients and when to refer these patients or to operate on cataract alone on these patients, I think it's definitely a decision by the retina surgeon. In the interest of the time, I think we will move on. If we have time in the end, we will have questions. The next speaker is Dr. Saravanan. I'm going to speak on another important topic on vitreomacular traction.
So regarding vitreomacular traction, it's very difficult to visualize clinically using a slit lamp under 90D or a 70-80D because it's all very translucent.
Ashish, video is here. Santam.
I'm hearing Dr. Ashish is in Switzerland.
Oh. also is not here.
So probably we'll have more time for discussion then once Dr. Saravanan and others will have more questions.
So OCT is a must to identify these very subtle and very transparent membranes. Without OCT is very difficult, even with the contact lens viewing system, it's very difficult to visualize these membranes. So whenever you have a doubt on thanks.
Slides are not coming.
Some here. See you on the top. Start moving. So when you have a case where you feel that the presenting vision is not corresponding to the amount of cataract or the level of cataract, then always make sure that in case you see a normal looking fundus with a dulling of foveal reflex, make sure that you get a OCT done. Apart from routine slit lamp examination, it's easily missed because it's all very transparent membranes and very subtle separation of the retina surface. And now people have, most of the cataract surgeons have included OCT as a pre-operative workup to avoid post-operative surprises and having the need to explain to the patient regarding what went bad or what was pre-existingly present and then make them understand. So vitreomacular attraction is nothing but a partial separation of the vitreous. Normally the sequence of separation is from the perifoveal area, the vitreous separates first, then the arcades, then the fovea, and then the periphery. So when you have an incomplete where it's attached to the perifoveal area, that's what we call this vitreomacular attraction. This can be because of trauma, inflammation, vascular disorders, a lot of things can, and age-related causes, all this can present as a reason for this. Normally, how a PVD develops is that you have a synesis happening in the vitreous body, formation of lacunae, which then move on to break into the posterior part, fuse into a large lacunae, and then break into the subaenoid space, cleavaging the vitreous from the retina. This is what we call as posterior detachment. And when this is incomplete, there is a persistent adhesion at the fovea, perifoveal area. That's what we call it as vitreomacular attraction. So when there is no tractional effect with only partial separation of vitreous still attached to the perifoveal area, we call it as vitreomacular adhesion. And this is mainly because partial separation of the vitreous is within the 3 mm of fovea. So when you start seeing tractional effects either in the inner retina or which can go on to produce cystoid macular edema like you can see here, or when you have a persistent traction full thickness macular hole, or like this partial thickness in the outer lamellar hole, or a full thickness macular hole with separation of the vitreous. These are all things can happen. Here you can see the earliest sign where you have a slightly indentation of the inner lacer retina. So all these, when you start seeing vitreomacular traction symptoms on the inner surface, or like in this case you can see the outer surface, there's some breakage here. It can be the inner or the outer surface of the retina. So when it starts happening, then we what is vitreomacular traction syndrome. So sometimes it's because very transparent and the additions are very small. Sometimes in 3D when you can make out it's even better seen than a routine 2-dimensional OCT. You can see here, you can see the 3-dimensional very spectacular view of the both the skytic vitreous and the riveted retina. So sometimes moving on to the 3D viewing system can sometimes give you a better perception of all the various additions in and around the fovea. So what to do when you have a persistent macular and the retinal problem? So if the cataract is a cortical type or when there's a posterior subcapsular cataract, usually the cataract is the main cause of vision loss, you can go ahead and operate. But especially in nuclear sclerosis, when your vision is not corresponding, always, as Raja was pointing out, discuss with the retinal surgeon and then make your plan of action rather than avoiding disappointment later on, after both from the patient's side and your side also. So what are the options for treatment is observed. If it's a very mild traction with not much of vision loss, then you can go into the cataract surgery and forget about the retina and follow it up later with your colleague. But when indications include when there's a considerable vision drop not corresponding to the amount of cataract, especially distortion, especially if the patient is a very high active professional, sometimes distortion can be a really big issue. So in those cases, it's better to operate either first or combined. So treatment options include, in India it's not available, in the Western countries you have the Jetria with very poor success rate, less than 1/3 of patients went into separation of the vitreous from the retina. So not commonly preferred, but this is one of the medical options where the patient is not willing for surgery in the outside world, not in India. So what we do here is surgical technique. You can see very stiff vitreous here where it's still attached to the posterior pole, fovea that is. So here you have to be very careful about separating the vitreous, not to include traction and convert foveal cyst into a full thickness or a lamellar or macular hole. So we try to do with low suction, try to make the central vitreous an island, and then go ahead with your peeling techniques. So you can see now we are trying to go around the fovea, sorry. To avoid converting a foveal cyst into a full thickness macular hole. So you can see now I made a small island. So at this point we have options of either stopping here and leaving it intact, because now we have released the traction, the foveal cyst will subside on its own. Or if you are not sure, you may have inadvertently created a macular hole, then you can go for a ileum peeling say next to that, so that when you peel the ileum, the separation of the vitreous from the perifocal surface is much more atraumatic, the lesser risk of causing iatrogenic holes. Okay, here now a peeling is being done, and with that you can see the foveal tag is coming off now. The last part of release should be the fovea, peel all around and then come to the fovea, and the final point will release the risk of converting this very thin walled foveal cyst into a full thickness hole is much more reduced. Here is one case where you have just left the small island intact, and you can see the foveal cyst is slowly subsiding. It will take a few months to attain near normal anatomy. This is a case of severe non-proliferative retinopathy with coexistent vitreomacular traction. Again, showing the same step. Where we are trying to do the, now first you have made the island into a small island. Now this is the completion of the vitreous island first with no suction and no cutting, high cuttings rather. So now we are going for ileum peeling now. You can see the ileum peeling using the asymmetric ileum forceps. The last part of separation will be the fovea. First you peel all 60 degrees around the fovea, and the final releasing point will be from the foveal surface. This way you can avoid the conversion of foveal cyst into iatrogenic macular. So sometimes you should be careful that all the three layers, that is the vitreous, the ileum and the epidermal membrane, can be fused into a single layer. And sometimes we are a little bit very forceful in inducing a PVD. It can rupture all the three layers together, causing iatrogenic macular hole formation. Whenever you have a very densely adherent membrane, be sure that you do it in a very slow way. Don't try to induce the PVD in a very forceful, like a routine case where you do it. This is just showing pictures of preoperative and postoperative. This is some of the published protocols which are available online. So my conclusion is that if you have a very mild cataract, do the treatment of the VMT first. If you have a significant visually obstructive cataract, go with combined you can do both phaco with vitrectomy. And phaco only if cataract is dense enough, you do not able to assess the posterior segment. You do the cataract first, then assess the retina, and then go ahead with your PR70 if it is needed. Thank you.
And same is true for lamellar macular hole. In fact, most of the lamellar macular holes do not require surgery. Same is for VMT, unless you have evaluated. So generally surgery is required, because most of the times you see most of the VMT do not have symptoms. It's basically an OCT finding. And even if the cataract does the surgery, a lot of these patients will improve. But it is the assessment pre-operatively, like you said, pre-op OCT is a must. And to avoid these surprises which a cataract surgeon may have, in case he has not done the OCT or in case he is not got evaluated by the cataract surgeon. So that message should go, because unless there is a full thickness macular hole where 100% combined surgery will be required, or majority of combined surgery will be required, most of the lamellar macular holes.
Yeah, that's what I mentioned. You can observe them in your them, but it depends on whether you think that is also part of the progressive vision loss.
Yes.
But I think from the cataract surgeon's perspective, I don't know how many here are actually VR surgeons. I'm assuming the others are only cataract surgeons.
So because there have been a couple of studies done, pre-op studies have been done, and from 17 to 20% there have been some indicating the outcomes. Therefore, the message should go louder and clearer. Pre-op is a must, even for a routine cataract.
Probably you are dealing with a very highly active person who is emotionally active, and they should expect normal vision post-operatively. Even a half-line drop or one-line drop, they get really upset.
Even in that, because if the cataract is significant enough, then I think they should allow the cataract to go ahead and get it. Rather than, you see, it's not 100% guaranteed that all retinal interventions will improve that one line also. So therefore, suppose cataract surgery has been done, and vision improves from say 618 to 609, maybe is happier, or 612. Or in case after that surgery, patient has troublesome metamorphosis, then maybe we have right.
Either the second treating doctor is always better. The first doctor always gives this outcome. Where you have the chance to be the second doctor, be the second doctor.
Yes.
And what about the
How often do you see worsening of the BMP post-cataract?
Very unusual. As I was saying, they are quiescent and they remain quiescent for long periods of time. Unless you have some significant post-operative complication with a dropped with an in-place or a PCM with a persistent inflammation.
You see, nowadays cataract surgery has become so. Cataract surgery has become so.
Safe.
It has improved so much apart from safety. The dynamics and endothelial motion does not happen much. Unless you have just disturbance, which is lost PCR or some drop, then you can expect some worsening. Otherwise, you see a routine phaco, which is they finish in most of them finish in 4-5 minutes. Generally, does not. You see, isolated case examples will be there.
Uneven cataract surgery is also cause PVD. So
It can. It is not a must.
It can actually also aggravate the diffractions to high.
What I'm saying is, isolated, there is not a very long series to say that all cataract surgeons, all after cataract surgeons will happen. It may happen, it may not happen. But by and large, because of the speed of surgery, because of improved instrumentation and surgical skills of cataract surgeon, most of the time this will not worsen. Most of the time.
what is the
Dr. Raja and Supriya. I'll be talking about cataract with macular problems, what to do when to treat when we have an choroidal neovascular membrane. Age-related macular degeneration, old age there are two trends, one is reading books and second is watching TV. In age-related macular degeneration, because many activities of daily living require central visual acuity, AMD decreases all aspects of patient quality of life, including the patient's ability to drive independently. And this leads to depression in elderly. So I'll be answering these 4 questions. Does cataract surgery worsen CNPF? When should you do a cataract surgery if you have an associated choroidal neovascular membrane? How does it help the patient in age-related macular degeneration? And what is the preferred macular? So first question comes, does cataract surgery worsens choroidal neovascular membrane? The answer is big no. There are multiple studies, and one of the largest studies is AIOC2023 studies, which spans over a period of 10 years. And in that 10 years, many patients underwent cataract surgery, and there was a mean improvement of +4 to +11 logMAR letters occurred after cataract surgery in AIOC1 and AIOC2023 study. The participants who had cataract surgery showed no increase in risk of AMD progression versus those who did not have cataract CNPF. Another 2 landmarks in the studies, Marina and Anchor trial, they showed that after cataract surgery in their study patient, there was an improvement of 10 logMAR letter, meaning thereby, and there was no worsening of the vision from the pre-op vision, meaning thereby cataract surgery does not worsen choroidal neovascular membrane, in contrast with diabetic macular edema. Now the second question comes, when should you do a cataract surgery? Surgeon should decide whether the cataract is hampering central vision if you have a central posterior subcapsular cataract or a nucleus sclerosis, then you should go ahead and operate this patient because it improves the contrast sensitivity in this patient. Screening of the macular disease with an ocular coherence tomography is a must in all age-related macular degeneration patients. And there is a study where where they compared the slit lamp bimicroscopy result with an OCT result, and the evaluator was an vitreoretinal surgeon. The overall management of 26% out of 411 patients was modified on OCT findings, which were either missed or underestimated by fundus microscopy. So again, what the previous speaker and what the members on the dais were speaking, that you should, if you are suspecting age-related macular degeneration, and you should go ahead and do an ocular coherence tomography to diagnose this disease. The third question comes, when should you do a cataract surgery? If cataract with CNBM is diagnosed at presentation, first treat the CNBM with 3 loading doses. Once the lesion becomes dry, then go ahead and do a cataract surgery. Cataract surgery is avoided within 6 months of starting the treatment for neovascular age-related macular degeneration. If lesion does not dry up, then you can go ahead with a simultaneous cataract surgery with an anti-VEGF can be planned simultaneously, and this is a small video where we have done cataract surgery and given intravitreal injection in this patient, and a direct chop is done. And once the cortical aspiration is done, after putting the lens and before aspirating the viscoelastic, we go ahead and inject anti-VEGF. That is 3.5 millimeters behind the fingers. Once the anti-VEGF is injected, then only you go ahead and do the visco wash. How does it help the patient in age-related macular degeneration? It increases the contrast sensitivity, thus helps in near vision. It also improves the BCVA and peripheral vision, thereby helping in daily activities, decreases the glare and improves the color vision, and thus helps with the quality of life indices. There is a study where if you do a cataract surgery in a patient with age-related macular degeneration, the incidence of fall decreased by 54% once you do one eye. And if you do both the eyes, then the incidence of fall decreases by 73%. So actually it helps the patient in its daily activity when we think that patient is blind and nothing can be done. Improved binocular visual acuity and contrast sensitivity were associated with decreased number of falls. So, which is a preferred IOL? The question what the last we were answering, unifocal aspheric IOLs are the best in cases of age-related macular degeneration. Toric IOLs do not compromise contrast sensitivity and can be used in patients with age-related macular degeneration. Multifocal IOLs should be avoided. That was the message 5 minutes before, and that's a message now, that don't use multifocal IOLs because it decreases the contrast and has a higher order aberrations. Evidence that EDOF IOLs are well tolerated in patients with age-related macular degeneration would be required before advocating them. To conclude, cataract surgery does not worsen age-related macular degeneration. OCT scanning is a must before taking the patient for surgery. Cataract surgery should be done after 6 months of initiating the treatment. Simultaneously, cataract surgery with anti-VEGF can be considered. There is an improvement in BCVA and contrast sensitivity, which improves the quality of life, and multifocal IOLs should be avoided. Thank you very much for your attention.
Thank you very much, Dr. I think the message is very clear on multiple aspects. One is that ARMD doesn't progress after cataract surgery. In fact, we looked at our data of more than 50,000 patients of ARMD, and what we found that actually after cataract surgery, the ARMD prevalence was showing to be higher. But when we looked at it very carefully, what was happening was, once the cataract surgery is done, within 1 to 3 months, when the vision is not improving, look carefully at the fundus and then start analyzing the reason why the vision is not improving. And also the fundus view is better. But if at all we expect increase in ARMD after cataract surgery, it should not be within 1 month to 3 months. It should be a long-term effect. But the entire increase was happening within 1 to 3 months. And that gives it, obviously the ARMD is not increased by the cataract surgery by itself. The other thing is the multifocal IOL. Please do not, there is no effect on the patient's quality of life. In fact, it could worsen the quality of life of the patient as well as the treating retina doctor. Both will suffer with that.
Yes, see, my take on this would be always treat CNVM first. Because in such, unless cataract is, obscuring the view, otherwise, I would go ahead and treat CNVM till the time macular dries. Because if the cataract is dense enough, in any case, your evaluation is not possible. I've seen it. Then you can, unless patient is following up with you and cataract becoming dense, and you have to give your, treat and extend next injection, then you do a combined kind of procedure. If cataract is not dense, you can evaluate very well. Always treat CNVM first. There is no doubt in that matter. I think whatever conclusion he has told, There is not even an iota of difference amongst the retina colleagues, whatever he has said. Yes. Comment
Talking about preoperatively you see bruising.
That is unrelated to the cataract. So preoperatively, if you see bruising, that is one of the definitions of macular disease. If you look at the AIOC classification, they should be. We are not talking about less than 65 microns. So the interrelated bruising more than 3 will come under the classification.
Just seeing the bruising, a large bruising.
Large.
It is an AMP or not.
Just drusen does not qualify into age-related macular degeneration. The definition is if you have a confluent drusen with a simultaneous decrease in vision of less than 6/9, then you define this patient as age-related macular degeneration.
So we move on to the next speaker, Dr. Supriya. She will be presenting in place of Dr. Pritam Samat, and she will be talking on management of post-operative cystoid macular.
Increased intraocular pressure. If that doesn't work, then we move on to intravitreal triamcinolone. The crystalline form has a longer lasting effect, and we can give the full dose, which is 4 mg or 2 mg in 0.05 ml. Risks remain the same, increased intraocular pressure. So if that doesn't work either, or sometimes if the patient is able to afford, then we switch to an implant also, which is a dexamethasone implant. This is 6 times stronger than the triamcinolone, and the possibility of a raised intraocular pressure is much less. Also remains in the eye for a much longer time, 3 to 4 months, with just a single injection. The complications of all these are raised IOP, floaters, pain during injection. Sometimes, very rarely, you could have vitreous hemorrhage, retinal detachments, and there's always the fear of any intraocular procedure of endophthalmitis. Off-label use of anti-VEGFs are there. If the patient is non-responding to steroids, then we can switch to anti-VEGF agents. The various ones in the market are Avastin. There's studies showing good improvement with all these modalities. How does it help? Again, with the vascular permeability, decreasing the leakage. If there's associated on the OCTs, if there's some VMT, then octoplasmin may be used to prevent surgery. But go in. There are some reports showing subthreshold micropulse laser, saying repetitive short pulses delivered at a subthreshold mode can decrease the edema. But if it's a low cost and may be considered as an alternative because it's non-damaging, you don't really get much foveal damage with this. Finally, if you see ERMs, epiretinal membranes, vitreomacular traction, then as my colleagues previously have discussed, vitrectomy is the only way to go with ILM peeling. This also improves the oxygenation to the retina and can decrease the edema in refractory CMEs. So mostly they're self-limiting, spontaneously resolves, but medical treatment can help it resolve faster. Chronic damage can lead to retinal thinning and fibrosis. So OCT is an excellent tool to diagnose these, and the earlier we intervene, the better in some of these patients to prevent the chronic retinal atrophy. Thank you so much.
And if time permits, we will definitely. Thanks, Supriya, for completely covering the topic in detail, lot of details. So next we have Abhijit to tell us about red eye. Red eye with pain. Will you divide red eye without pain, with pain?
No, sir. I just kept what are the causes of the red eye, because the full book can be written down there. So let me try. Thanks for the recording. So yeah, so up to 34% patients report in first few hours some discomfort and pain and redness, and it can persist up to 6 weeks. And most of the time, the thing which we prescribe, I will show you. So the possibilities, what are the possibilities? Which is swelling of the eyelids, subclinical hemorrhage are very common. Allergy, dry eye are the next most common. Then there will be causes like Fuchs dystrophy and recurrent corneal erosion, increased intraocular pressure, endophthalmitis, of course traumatic surgery and node perforation. And the initial things which we give, it is artificial tear substitutes and NSAIDs like paracetamol. And if it does not improve the situation, then only we think of the serious ones. So I just discussed few of the more serious problems like the iritis, the photophobia and circumciliary congestion will be there. And usually there will be previous history of uveitis or maybe eventful surgery like vitreous loss, lens particles, iris injury or hemorrhage. Usually we get mild to moderate anterior vitreitis and definitely will not get much vitreous involvement. Management is conservative mainly. Then we get the raised intraocular pressure. Usually the visco will be left in the antechamber, then maybe the patient was previously glaucomatous. There will be definitely chances of vitreous loss, then lens particles and vitreous in the AC. And this is also treated by mostly conservative methods. So then we get the most dreaded two, the toxic anterior segment syndrome TAS and the endophthalmitis. So about the TAS, we care is acute severe reaction with vision loss, pain and raised intraocular pressure. Usually we get in 1 to 2 days post-op compared to the end of which we get after 3 to 4 days post-op most of it. And diffuse corneal edema with photophobia, severe antechamber reaction, maybe hypopia even. And the causes are described as bacterial endotoxins, BSS, denatured viscoelastics, etc. USGB scan will be definitely normal, and if we do AC and vitreous tap to rule out endophthalmitis, they usually come negative only. And these are the, we usually conservatively managed, mostly topical steroids, sometimes many systemic steroids, results within 3 to 6 weeks, and made it surgery also like keratoplasty, AC was given some cases of described with IOL removal. This is with the conservative management we can see, and this is after disc surgery. And usually if it persists more than 6 weeks, there may be irreversible damage and loss of vision to the patient also. Then the endophthalmitis, which is most dreaded among us. There will be decreased vision, pain, lid swelling, congestion, corneal infiltrate, definitely AC reaction with hypopia plus minus, and there will be defective pupillary reaction. So when we suspect, clinically we diagnose it with slit lamp, fundus giving and ultrasound, and then we treat promptly. See, so this is the progressive vitritis is the hallmark of any kind of endophthalmitis. So the most common thing which we, even the anti-semen surgeons also sometimes send the patient to us thinking it is TAS. So the serial ultrasound is a very important thing, and if we are in doubt, we can always take ACT sample and give intravitreal and see for the result. So intervention, we do AC or vitreous tap with intravitreal antibiotics urgently for stain culture PCR, which can be done by anti-semen surgeons also. Then we usually prescribe topical antibiotics with topical steroids hourly with mydriatics, and also we prescribe systemic antibiotics. Vitrectomy if it is not responding or vision is less than hand movement, in case of diabetics, then particularly post-trabeculectomy, all those cases. This one small video which we do is looks like bad, but see if we treat them, it gives good results. So first we put a AC maintainer and remove the anterior membranes, which you can see because you cannot see anything much there. And then we clear the anterior space, and this is the 25 gauge we used. And then we can see the inside is there is lots of vitreous haze with pre-retinal exudates. So we clear them up with vacuuming, and then we cut as much vitreous as possible, but where we cannot see, we don't go rigid to that way. And we try to finish the end point, we keep it as the posterior pole healing. And we give the intravitreal antibiotic after that and see the result also. So this is the before and this is the 4 days after the pole vitrectomy, and after 10 days it's nicely clearing. And thank you. And this is this one invitation for our next AIOC2023. Thank you, sir.
Thank you, Jit, for the clear messages. I think now we have Sonal to tell us about premium IOL. I don't think you should have more than 2 slides. Because already I think it has conveyed a lot of messages about that. And Abhijit, the best is to divide red eye with pain into vision loss and without vision loss.
Yeah,
that will be better.
Things, minor and bigger serious things I can imagine.
Yeah. Yes, Sonal.
Thank you so much, sir. Yes, I should all about calculations and just having minimum slides, but I think we still have a lot to discuss, an interesting topic which I think is of prime importance today to I think a lot of retina surgeons. The human eye's natural ability to accommodate and refocus at varying distances in a pre-presbyopia eye is matchless. But today with premium intraocular lenses designed to have better technology with latest innovations, we have the ability to give a glass-free vision to most of our patients. These IOL technologies refer to the biomaterials, aspheric design and special refractive properties of these lenses. Advanced surgical techniques and IOLs have increased patients' expectations by giving excellent post-op visual outcomes. But no lens is perfect except the one that you're born with. And a huge number of them are there in the market today. We have toric intraocular lenses correcting astigmatism, multifocal, bifocal, trifocal, toric multifocal and EDOF lenses. Multifocal lenses give spectacle-free vision for near, intermediate and distance vision, providing more than one focal point by splitting the light into several focal points. They may be bifocal with 2 focal points and trifocal with 3. A concept given by Hoffer in 1983 for the first time and Pearson 86 doing the first implantation. Toric IOLs help us in correcting astigmatism with glass-free distance vision. Multifocal torics also give us spectacle independence irrespectively of the corneal astigmatism for distance, intermediate and near. Accommodative lenses give us clear vision at near and distant focal points, giving a dynamic increase in the dioptric power of the eye. This was first approved accommodative IOL in 2003 by Crystal Lens, which was the first one. These are position-changing single or dual optic IOLs, and though we don't use much for accommodative IOL designs now with EDOFs coming into. These IOLs have a longitudinally extended focal point by using optical properties with a continuous change of power from the center to the periphery.
Can we stick to cataract and macular disease?
Okay, fine, sir.
Because this is not an IOL session.
No, I know, sir, but so IOL in a macular disease, which is sure, sir. IOL in a macular disease is a tricky situation. Macular diseases decrease in the contrast sensitivity. Conditions like AMD and diabetic retinopathy tend to progress after cataract surgery. Post-operative visualization of the retina is of utmost importance in treating and monitoring these diseases, and pre-operative OCT is a must to rule out macular pathologies if a premium IOL has to be planned. Coming to simple things like multifocal and trifocal IOLs with multiple rings decrease the contrast sensitivity and are thus a contraindication in these patients. They also pose problems in visualization of the peripheral retina and also for us to do further treatments like lasers or intraoperatively. Diagnosis and treatment of macular pathologies tend to progress after cataract surgery, can be adversely affected by these premium IOLs. So, in contrast to trifocal IOLs, monofocal or EDOF IOLs can be helpful in patients with milder macular pathologies, and toric IOLs are not a contraindication. Patients without any clinical evidence of a macular disease but with a strong family history are treated to be as normal patients, and all IOL technologies can be offered to them. With early maculopathies like soft drusen or pigmentary changes, have loss of contrast sensitivity at lower spatial frequencies and are difficult to counsel, and IOL selection is a challenge in these patients because they have good Snellen's visual acuity. So, keys to success with premium IOL is a careful patient selection and preoperative workup of paramount importance, a clear communication, proper education regarding the IOL, work in the best interest of the patient, and select the IOL judiciously. So very early or mild maculopathy, a monofocal or an EDOF IOL can be preferred. Even in a patient with an epiretinal membrane, a monofocal IOL can be preferred, and in some cases if the surgery has gone well and you have achieved your foveal contour well, you can even consider an EDOF IOL. In moderate to severe maculopathy, we do prefer not to put EDOFs or multifocal IOLs. In a one-eyed patient, we do not consider multifocal IOLs because they don't adapt to one-eye implantation. night drivers, pilots, watchmakers, patients with high myopia, so we do not prefer multifocal IOLs. Patients who have high astigmatism, we prefer toric IOLs. So these are certain conditions of the retina where we prefer monofocal or in some cases EDOF IOLs today over multifocal IOLs. Thank you.
That's the reason I said 2 slides will be good enough. The message will be only, if patient has a concurrent macular problem, trifocals as previously over discussed, this multifocal should be out. I think we'll, before Mudit and some postdocs we'll take up at the end, because let's finish with Dr. Vishali. Then we talk about the pre-op and post-op protocols, because that will be more relevant for the patient.
I have been given a topic of posterior uveitis and cataract, and I will restrict only to posterior uveitis, not to pan or anterior. So you have a situation of cataract with active posterior uveitis where you understand the etiology. For example, this is toxo written on the face of it. So treat the posterior uveitis first. Give the specific therapy. Cataract surgery in these cases can be undertaken as soon as the posterior inflammation has responded to therapy. There is no need to wait for 3 to 6 months of quiescence if you are dealing with only posterior uveitis, and there is no need for any preoperative steroids. You have a second situation, you have a cataract and there is a healed posterior uveitis which could be of known or unknown etiology. You could plan a cataract surgery with no extra precautions. Visual prognosis remains guarded and that has to be documented photographically and the informed consent to be taken accordingly. There is no documented study to say that there is a risk of reactivation of posterior uveitis secondary to the cataract surgery, so there is no need to go overboarding with the prophylaxis and putting some funny drugs in the infusion. The third situation is the cataract and there is an undiagnosed posterior uveitis. For example, this young girl belonging to New Delhi Super VIP's daughter had cataract and had posterior uveitis which had been treated with almost every possible therapy. But it was not really responding to therapy. She's young, 25. So what we could see, there was a peripheral granuloma, there is haze due to vitritis as well as due to cataract, and there is this granuloma sitting for which she had received ATT, there was no response, and then she was being planned for drug, another course of ATT. Now these are the kind of the patients you can straight away plan a combined phaco, IOL, vitrectomy, and I would suggest 27G vitrectomy because that's where you are going to have a closed system. And if you are combining it with vitrectomy, don't forget to put the sutures, no ego involved, because these uveitic eye, even with this small gauge, as you can see this one, can end up hypotony the very next day. When you are doing combined, do it under air. First take a good vitreous sample which is undiluted, and then of course you switch on to infusion, take the sample, and the rest is actually easy. So this is the post-op. When we did her PCR, she had rifampicin resistant, which was detected. She was treated for drug-resistant TB, and this is the 2-year follow-up, and you can see this granuloma has responded and her cataract is out as well. The last situation is a patient like this, again from our capital, acute retinal necrosis, this 46-year-old male who's a techie by profession. He says he had sudden decreased vision in the left eye. At center A, shown, all uveitis workup negative, given oral steroids, no response, developed kind of exudative detachment, and he did give history of viral encephalitis in the past. So when we saw him, he had exudative detachment for sure, which was not truly exudative anymore, because if you see slit, he was developing a detachment, and within 2-3 days, I wanted to give him a cover of acyclovir because it was a very active eye, but within 2-3 days, he developed severe cataract and the detachment progressed, and you can see a seed-like retina. Now, if there is a situation like this is 72 hours later, you can see how quickly everything is worsening. So if there is a situation like this, please do not plan IOLs or anything, because here the aim is very different. The aim is just to save and salvage the eye, get the thing and save the opposite eye with viral. So this one was more of a viral. Patient underwent carsplenolensectomy with vitrectomy, and it was done in a very, very acute phase. So during the acute phase, when there is anterior segment inflammation, posterior segment inflammation, retinal necrosis, don't be over ambitious, don't put IOLs, simply do the needful what is required at the moment. So with this, and this is the post-op of the same patient. So conclusion is you customize your surgery as per patient's need, because every size doesn't fit everybody. So, see what is the need of your patient and decide accordingly. Thank you very much.
Thank you, Vaishali. As usual, four very crisp messages, and two were very obvious. Last two required emphasis, and that has been done. So, thanks. I think we'll move on.
Cataract again with macular problems, and is my pre-op protocol correct? And I think the previous speakers have elaborated upon so many macular pathologies and the role of retinal surgeons in them, or for that matter, role of cataract surgeons in working along with retinal surgeons and taking better care of our patients. And the most important message is a good pre-op evaluation, which involves doing a good retinal as well as a complete evaluation. What we often forget is that we have to treat the patient as a whole. So we are looking at the entire eye as a whole, not just cataract or macula or any absolute anatomic segregation of eye. You look at the patient as a whole, and Dr. Savaran had shown the importance of OCTs or pre-op OCT in these cases. And the most important message that he had also given was, if your patient's visual acuity is not corroborating with the grade of cataract, that means you need to look at what else is happening in the eye. And so, what are the more important parts in any pre-op protocol? Number one, look at the systemic parameters of the patient. Is the patient systemically stable? Is he an uncontrolled diabetic? Because that can have adverse effects. Look at the zonular status of the lens, and more importantly, look at refractive surprises. Take a meticulous history, correlate vision. Meaning thereby, if your vision is not correlating with the grade of cataract, means you need to look at what else is happening. Look at the retina or look at the macula. So a lot of macular pathologies can go on to have an effect on the outcomes of a patient, and it's important for us to look at the retina and the macula not only in terms of offering treatment, but also in terms of prognosticating and explaining to our patient the visual outcomes which can happen. Because like we have discussed, patients will be expecting a visual acuity of 20/20 post-surgery, but that can be hampered by an underlying macular pathology. And as surgeons, it becomes important for us to explain to our patient what is an underlying pathology, how it can play out in future, and what can be its effect on the future prognosis. We have had discussions on macular edema, epiretinal membranes, macular holes, vitreomacular traction, and diabetes. So I'll just show you a few cases where it was important to look at the retina for us to determine the future outcomes of the cataract surgery. So a comprehensive evaluation, a need for it can obviously not be understated. Visual acuity, slit lamp, look at optic nerve status in the terms of RAPD. Check for any neovascularization. So if there is any NVI or NVA, important for us to do a gonioscopy. See if there is underlying vein occlusion or any neovascular glaucoma which is developing. IOP, fundus examination, and obviously OCT and angiography or a B scan when required if you can't visualize what's happening. So if you have a cataract where you cannot visualize the retinal details, it becomes important for us to at least get a pre-op B scan done to see if there is any underlying retinal pathology which may adversely affect the outcomes. Moving forward, so this was one patient, and these are patients who were referred to us post-cataract surgery. This is a patient who had undergone a cataract surgery, then came to the retina clinic with an unexplained decrease in vision, and what this patient has is an obvious macular hole. Another patient was a known diabetic, but when we did an evaluation, we found not only that the patient have a MACTEL or a parafoveal angioedema, but also had this vitreomacular adhesion over here. These are all patients who need a concurrent management of the retinal pathology too. Now this was one more patient, 2040 advised for cataract surgery, but what this patient also had was a pre-ILM hemorrhage, and along with the pre-ILM hemorrhage he had this small, very subtle, wide-centered hemorrhage, or what we call a rod spot. We got this patient examined, and this patient surprisingly
turned out to be a patient of CML. So we were the first ones to actually diagnose CML in this patient. And this patient, a visual acuity of 20/40, had been advised for a cataract surgery, but a retinal evaluation revealed an underlying blood dyscrasia. And that's why it's important for us to look at the macula, look at the retina as part of our routine pre-op evaluation for all of these patients. Again, patient become with cataract with multiple diffuse fine stellate KPs, no cystoid macular edema, no CT, no synechiae. These are patients of Fuchs uveitis syndrome. Again, we need to just tell them that sometimes post-cataract surgery, they will have a problem of persisting floaters. So the importance of a pre-op evaluation is not just in prognosticating, but also in helping our patients in their future management and in guiding them as to what to be done next, and as to also guide them on their expectations post-cataract surgery. So look for signs of inflammation. We just had a talk by Dr. Vishali ma'am, where we were discussing about the role of cataract surgery in post-uveitis. But if your patient has had a past history of ocular inflammation, has had a complicated cataract, look for any persisting signs of inflammation. If there is active inflammation, usually a cataract surgery can be deferred. If it's an absolute emergency, you may do it under cover of steroids, but ideally at least a 3-month quiescence post resolution of inflammation. So one of our patient was referred for cataract, but had actually a peripheral spontaneously attached retina, plus peripheral retinal necrosis over here. Another scenario where it becomes important, probably we could have discussed about diabetes and its role in cataract later on. But the point over here is that it becomes important because you may have these underlying pathologies. Diabetic macular edema can worsen post-cataract surgery, so you may probably either treat them with a concurrent anti-VEGF agent or a steroid implant also along with the cataract surgery at the same time. So in a nutshell, take a good history, correlate vision with your cataract grading, and a complete ophthalmic evaluation has to be a part of our pre-op protocols. Thank you so much.
Thank you very much for that. And I guess there is one last talk about is my post-op protocol correct by Dr. Vishal Kishore.
Morning everybody. So on to my talk on is my post-operative protocol correct for patient with macular disease undergoing cataract surgery. Now why this special care, why this concept of having a special care post-operative? Now we all know that patient with retinal pathology, their eye itself inflamed, and then post-cataract means when we subject them to cataract surgery, we subject them to iatrogenic surgical trauma, which starts a cascade of inflammatory process, so it can lead to some complications. So following a rigorous protocol for patient preparation, surgical technique, and post-operative control can help to minimize the risk of complications and achieve good post-operative outcomes. So after this, next question is, will the cataract surgery make the macular degeneration worse? Now, our previous speaker has said there is such no correlation, but few studies just on the basis of concept that eye is inflamed in retinal pathology and cataract causes inflammation, so it can cause progression. There are few studies, but AIOC2023 has categorically stated that there is no progression, means they have evaluated large number of patients followed for at least 10 years, and they have come to a conclusion that there is no significant difference in patient of AMD who has undergone cataract surgery and who didn't have the cataract surgery. There is not significant progression of the disease. Then comes the most important protocol, which is important both pre and post operative. It is the counseling. You have to give a good chair time. We all know that in a normal population, if we subject them to cataract surgery, then post cataract they have wow factor because they can see the significant difference pre and post surgery. But in this patient with macular diseases, this wow factor is missing. So you need to give chair time. You have to counsel the patient. Like you have the macular degeneration, your vision will not be as optimal as expected by a normal population. So you'll have to have other visual aids, or you have to give chair time. You have to counsel them according to the disease. Then other area of concern in post-operative care, like these patients, since they are subjected to various intravitreal injection pre-operatively because of the disease process, so there's chance of end up. And then the next question comes, if at all these patients requires anti-VEGF or any other intravitreal injection, what should be the frequency post-cataract surgery? And then lastly, as we have discussed in the counseling part, this visual aid is important in the terms of either additional lightening, magnification, or reading aids. So since these patients had previous intravitreal injection, so we have to follow strict and over-suspicious post-operative vigilance in patient with a history of intravitreal injection undergoing cataract surgery. This is a must, so that we don't miss this subtle this delayed onset of pneumonitis or any other subtle complications which could be easily treated. Then comes whether we need any extra intravitreal therapy for patient with macular degeneration. This is a big no for this, as discussed earlier in the previous talk. So as proven by a long-term study, edits too. So we don't need any extra therapy. It's just the same protocol which is followed before and after surgery. Then when should we give the intravitreal or anti-VEGF injection, whether if required in case of diabetic macular edema or any other macular pathology. Now some retinologist recommends that we can give anti-VEGF approximately 2 to 4 days before surgery or immediately at the end of the surgery. Some of the are of the opinion to give anti-VEGF on PRN basis after 1 week of cataract surgery. Some they suggest that you can inject slow release this intravitreal drug implant like Ozurdex, which will control the inflammation. And in case of diabetic retinopathy, some is of the opinion that once the cataract is removed, you have clear media, you can easily assess and grade the retinopathy, and then decide whether you will go for photocoagulation or the anti-VEGF. And finally, once the patient, this media is clear and you have removed the cataract, you can assess the macular degeneration, and if his vision is not improving to his what he was expecting, then you can just counsel these patients for low visual aids. Now there are many modern portable electronic devices with flexible use of magnification, and these could be counseled to these patients. So to summarize, rigorous follow-up is essential to minimize inflammation after surgery. Routinely these patients are put on topical steroid and NSAID, and NSAID should be continued at least 3 months post-operatively, and we recommend like anti-VEGF injection should be given 1 month post-operative and then follow up with the retina UV. Thank you.
So thank you so much. I think most of our topics and speakers have adequately and nicely covered what are the points which anybody, not just cataract surgery, but all ophthalmologists should keep in mind when we are going there with cataract surgery for our patients, and how macular diseases can impact the post-cataract surgery outcome as well as the prognostication of these patients in the future. So thank you so much. Alright, thank you so much for joining us today for this session, and thank you to the organizers.